Dr. John Torres of NBC News on his Facebook Live, covering some topics of the pandemic, of the coronavirus, of different things that are happening with that you might have heard over the weekend or the past week. Getting a little in-depth into these headlines so you have a better understanding of what it means, not just for you, but for your family, your loved ones, and your community. So that way you can help yourself and them and your community get through the pandemic sooner rather than later. And then I'll answer some questions you may have. So if you have questions, please send them our way. The questions are fantastic, and we'll get to as many of those as we can. But first and foremost, last couple times, and my apologies, we have had some sound issues. So if you can't hear me this time, let me know, please, and we'll certainly adjust as best as we can, but hopefully we've worked things out, so we'll find out for sure. But first thing I want to do is talk about the different parts of the pandemic right now and where we are. So right now, if you look at the sheer numbers, the numbers are still going very, very high. We're going right around 200,000 cases a day. Every now and then it'll drop down to 170,000 cases, go back up to a little over 200,000 cases. And so it's certainly increasing across the country. And some areas are having more problems than other areas. Now this is not unexpected because we know the holiday travel that was over the Thanksgiving weekend, and particularly the week before that. It takes about 2 weeks for those cases to start kicking in. We're at that point right now, between now and the end of this coming week. And so we're going to see those numbers go higher. Unfortunately, this time period also coincides with the holiday travels that are going to start to come up in a couple of weeks. And that's why health experts across the board are saying, please don't travel. Please don't travel this holiday season. Let's all stay home. Let's do things virtually as best we can, but just give everybody that one holiday to get the pandemic under control. And then by the next holiday, we can get back to being with our loved ones, which is something we all very much love to do. But looking at sheer numbers, here in the U.S., NBC is reporting almost 15 million cases, 14.848 cases, 14.848 million cases here in the U.S. since the start of the pandemic. 283,000 deaths because of that, and that's deaths since the beginning of the pandemic. If you look at the death rate right now, we're talking about 2,000 a day. If you look at that and push that forward, Dr. Redfield with the CDC said maybe 450 deaths total by February. And at first glance, you're like, that seems to be a little alarmist, but if you look at the numbers, probably not, because 2,000 a day, you figure we have most of December to go through, most of January to go through. We're talking, probably 60 to 120,000 cases. We're at 280 right now. That puts us right at 400,000 cases, and that's kind of middle of the road kind of thought. Okay, this is where we are right now. This is not certainly the worst case scenario. So again, the numbers are going very high, and because of those high numbers, different parts of the country are doing lockdowns. Now, the lockdowns we're seeing right now aren't like the lockdowns that we saw back in the springtime. Those were universal lockdowns where a whole city would completely lock down, and they would say, everybody stay home, let's get this under control, let's do this for weeks and weeks, and in some cases even months on end, and then things started opening up. Well, we learned from then what we need to do, and these are targeted lockdowns. The example, California. California has very specific lockdowns of what they're doing right now, and essentially what they're doing is they are looking at having these different lockdowns in different parts of the state, mostly the southern and the central part of the state. And Delaware, the governor actually put a word out saying, hey, we want you to stay at home. And by stay at home, we mean don't be with anybody other than the people that live under your roof. And it's important to do that to keep from spreading coronavirus. Here in Colorado, where I live, they are doing county by county lockdowns depending on where you are in the pandemic in your own county. And I'll explain that in a minute, because what is happening with these lockdowns, as opposed to back in March, April time frame, when the county governments, the city governments, the state governments would say, okay, we feel like this is getting out of control, let's go ahead and lock everything down and try and get it under control. Since then, they've all come up with specific criteria. And the criteria they use in California is ICU capacity. If ICU capacity gets very thin, then they're going to go ahead and say, let's lock down that county for a few weeks, in this case 3 weeks, so we can get that ICU capacity opened up again, because last thing you want are no ICU beds when patients need that. Here in Colorado, they're using a system, they call it the COVID-19 dial, and it goes from green to purple. And so at green, just about everything's open up, or as best it can during the pandemic. At purple, just about everything's shut down. Right now, my county that I'm in is in the red. A lot of counties in Colorado are in the red. They're using specific criteria. And that criteria, hospital admissions, case numbers, positivity rate. That criteria was set up a little while ago, a few months ago, And like it is in California, like it is in other places, this is criteria that was looked at from a scientific basis, saying, okay, at what point do we think positivity rate is the point where we need to get it under control? At what point do we think hospitalizations are where we need to get them under control? Where's that number? And when we reach that number, automatic lockdowns. And so that way, there's not a lot involved with it politically. There's not a lot involved with it, with people saying, hey, you're playing favoritism or not favoritism. In this case, they're automatic lockdowns. Same thing in California. They decided to go with ICU capacity rate. Once they reach a certain number of people in the ICU and that capacity gets diminished to a certain level, they're going to lock down that county, let the ICU catch back up. Here in Colorado, they're locking down the counties, letting things catch back up and things get better. But the lockdowns don't mean what they meant back in March and April. Not universal lockdowns. They typically tend to be bars and restaurants closing, just outdoor dining perhaps, or perhaps even just to-go dining. They also are saying, you know, that sometimes hair salons, sometimes barbershops will be included, sometimes they won't be included. Movie theaters are often included, places where people congregate. And then they say, no, nobody can congregate with anybody outside their own household, because you want to make sure you're not spreading it that way as well. And they're talking about this lasting for a few weeks and constantly looking at those numbers so when they improve, they can start opening things back up again. But the important driver here is human behavior. And what we're finding out is the more that people help get the pandemic under control, the less we're going to have these lockdowns. And that human behavior component is important. And by that, we mean the things I always talk about. Wearing a mask, washing your hands, watching your distance, and gathering in small groups. You don't want to do that. Only be with people under your own roof. And again, we're doing this until we get that vaccine. Once we get the vaccine and enough people vaccinated, then we'll probably only have to do this for a little bit longer after that. And then we can get back to at least a near normal and hopefully a real normal over the next year or so. We'll find out. But that leads me on to the vaccine news you've probably been hearing. So this week is going to be an important week for a couple reasons. Number one, the Pfizer vaccine was approved in the UK a few weeks ago. They're going to start giving shots in arms in the UK. England, Scotland, Wales, Northern Ireland is a little bit delayed, but England, Scotland, Wales will start giving those shots tomorrow. And so this is the first country in the world that will be giving COVID-19 shots on a mass level. And what they're giving them to now is they decided, as opposed to the US, we have a little bit different criteria. They're going to initially give them to people over the age of 80 who are living in nursing homes or care facilities, and to care workers who are taking care of them. That's going to be the first salvo. The second salvo are going to be healthcare workers. Here in the U.S., we've defined it a little bit differently. Those healthcare workers are going to be one of the first ones to get it, and people in long-term care facilities. It's not necessarily an age requirement, but people living in long-term care facilities. Again, that Pfizer vaccine a couple weeks ago, it was approved in the UK. This week, on the 10th, which is Thursday, VRBPAC, which is the advisory committee to the FDA, is meeting to advise the FDA on whether they think the FDA should go ahead with an emergency use authorization. By all indications, this will pass, and it will get its emergency use authorization Thursday the 10th. Moderna, a week behind that, will be Thursday the 17th, and again, we think that'll be the same type of thing happening there. The reason for the delay between the UK and here, and this has caused some consternation, is the UK uses a different method to analyze their data, a different method to look at the safety and the effectiveness of the vaccine, which we all agree is the paramount thing here, the safety and effectiveness. Here in the US, the FDA is sort of the gold standard for the world as far as how they look at the data and how they make sure that these medicines, these vaccines are safe for us and they're effective for us. And so the UK takes data from the manufacturer, and for the most part, the data is interpreted by the manufacturer, and they get essentially a summary of that interpretation. And they look at that. If they have questions, they go back in and they get the data from there. But they look at the overall data and the summary of the data from the manufacturer. Here in the U.S., instead what they want is they want the raw data. They want to go through it themselves, which takes more time. And that's why there's that little bit of delay here by a few weeks before we get our vaccines authorized here in the U.S. Now, once that vaccine, the Pfizer vaccine, gets authorized on the 17th, they think the following week, Monday, Tuesday, we're talking 14, 15, 16th time frame, that they'll start getting shots in arms. Here in the U.S., the CDC has already said that the first people to get the shots are going to be frontline healthcare workers and those living in long-term care facilities. They estimate there's around 24 million of those. We think we'll have 40 million doses by the end of the year between Pfizer and Moderna. So we're going to be a little shy of that 24 million, and they're trying to wrestle with that right now about how to either get more vaccine or who should be prioritized in that group. And in the next group, essential workers, and then the group after that will probably be those with pre-existing medical conditions. At least that's what it's looking like. But so far, the CDC has approved frontline healthcare workers and those living in long-term care facilities, nursing homes, to get that vaccine. And so, again, expect to hear news over the next week or so about the vaccine's authorization, not approval. Approval is a permanent thing that's usually done over a very long period of time. And authorization, emergency use authorization, is done in times like this, times of pandemic, when that vaccine needs to prove it's safe and effective, but also needs to be gotten out as quickly as it can, because we need to use it to end the pandemic. Now the question comes, so here's the issue. Both with Pfizer and Moderna, they're 2-shot vaccines, and they're either 3 or 4 weeks apart. So if you get a Pfizer vaccine, the first one, which is sort of the primer vaccine, you need to get a Pfizer vaccine, the second one, which will be the booster vaccine, over that 3 to 4 week period. If you get Moderna 1, you have to get Moderna 2. You can't get a Pfizer one and then go back and get a Moderna vaccine. It won't work that way, because they're both essentially, they're made a bit differently, and so they'll both essentially be primer vaccines. You'll never get that booster vaccine. And so what they're going to do is they're going to issue cards that are going to be used. So when you have yours, you'll get a little card that says, I had my Pfizer vaccine, or I had my Moderna vaccine, first dose. And then when you come back 3 or 4 weeks, you'll get another. You'll basically have the healthcare provider look at that and go, okay, you need the Pfizer or you need the Moderna. That way, there's no confusion. Now, of course, there'll be hiccups like anything else, where people will lose their cards, or they can't find them, or they didn't bring them with them. And so they're going to have to iron that out in the system to make sure that those wrinkles are taken care of. But one of the important things to remember, again, is that this will be happening real time over the next couple of weeks. Now, another difference between the UK and here, the UK are setting up mass vaccination centers. They're doing it in stadiums, they're doing it in libraries, they're doing it in parking lots. Here in the US, for the most part, it's going to follow our normal distribution scenario, where it usually goes through third-party vendors who get it down to the hospitals and the clinics. However, a little twist on that are going to be the public health departments that are going to be involved. I recently did a story on a nightly news over the weekend, last night, if you want to take a look at it, that looks at Denver and what they're doing in particular. And what the Denver Public Health Department has done is they have essentially gone to the people with flu vaccines to do a rehearsal for what happens with the COVID vaccine. And they found out some very good lessons. I initially talked to them in September, got my flu vaccine in one of their clinics they had. It was an outdoor clinic going into the community neighborhoods. And what they found is they really want to get to those that are most vulnerable. And those are the ones that are in communities of color, particularly in underserved communities, and they want to get in there. A couple things they found out. Number one, if you get a healthcare provider in there, if you get a public health official in there, they'll sort of listen to them, but if you get a community leader, they will very much listen to them. And so they're working with community leaders to convince them, answer their questions, get them an understanding of how safe and effective the vaccine is, and then they can address their own community and say, we should be getting this to help ourselves and each other out, and the community out. The other thing they found out is timing works. And so initially they had some morning clinics, nobody showed up. Afternoon and evening clinics worked better because people were working, getting it into those areas, like even firehouses, community centers, those types of things where people could go to. The firehouses worked great because they brought their kids along. The kids were mesmerized by the fire trucks, and the adults were getting their vaccines, and so it worked really well. And they're hoping to make those community connections to do this. And that's what it's going to take. As opposed to people coming to the vaccine, which is what the UK is doing. Here in the US, they're trying in certain areas to get the vaccine to go to the people. And that can be an easier reach for them, and easier, more confidence in the vaccine, more trust of the people giving it to them. Using mom and pop pharmacies around the country can help as well, because they have a bigger connection to the community. All these things can help get the vaccine to the people. The important part is that we get that herd immunity, which we were talking about 70%. Some experts are saying maybe even 90% of people need that herd immunity. And so again, we're getting close to that. So again, looking at the topics we talked about, number one, the numbers, over 14, almost 15 million cases in the US, almost 300,000 deaths. Those numbers are going to go up. So trying to keep that travel under control is going to be extremely important. The lockdowns that are happening across the country, they're going to be smaller lockdowns, more targeted, but they're lockdowns that are based on criteria that's already been established. And once that criteria is hit, then those lockdowns become automatic. And then the vaccine, a lot of good news on the vaccine. The UK is going to start giving out their vaccine tomorrow, so we'll get information on how that's going. We're going to probably start giving our vaccine out a week from now, both the Moderna vaccine and probably a week following that, the Pfizer vaccine, a week following that, the Moderna vaccine. And so more to come on that, and I'll certainly come Friday talk about what happened Thursday with the committee meeting for the FDA and the emergency use authorization. So now let me see if you have any questions.
Do you believe that the rapid COVID-19 for airplane travel is reliable?
I do believe that the rapid COVID-19 test for airplane travel can be reliable, but it's also one of those things that you have to realize that with the rapid test, let's use what we call antigen tests, they do have a higher false negative rate. In other words, people can test negative and in fact have coronavirus that they could spread to others. The beauty behind those tests is they're cheap and they're rapid, and so if you do a lot of those tests over a long period of time, then you get an idea of who has it, because each time you catch more and more people. And so what I say is, okay, if you get that test and you're positive, then you know you're positive. You shouldn't fly. If you get that test and you're negative, it sort of gives you an answer, but only part of an answer. And so you want to make sure that you still follow all the different procedures, wearing masks, social distancing, washing your hands, those things to make sure you don't spread it to others in case you do happen to have it. So even though you test negative, you can't really sit back on your laurels and say, I'm fine, I don't need to do these things. And that's for both tests, PCR and antigen tests. But realizing that the antigen test has a much higher false negativity rate, especially if you don't have symptoms. And so that can be a bit concerning. But again, it's a great test to use in appropriate situations, and that's usually testing on a rapid basis over many, many days, or using it to screen out those that have it, but not the other ones still have to do the same things that we all have to do to keep ourselves and others safe.
Have the vaccines been tested on high-risk individuals? Should I take it?
So has the vaccines being tested on high-risk individuals, and should you take it? As for should you take it, yes. Has it been tested on high-risk individuals? Yes, it has. So what happened with these clinical trials is the first and second trials, human trial 1 and 2, are usually done in smaller numbers on healthy adults. And then when they come to the third trial, they usually open up the criteria a lot more. And in this case, they wanted to do a couple of things. They wanted to make sure that it was tested on people that had pre-existing medical conditions, high blood pressure, obesity, diabetes, those things that we know put you at risk, heart disease, those things that put you at risk for complications from COVID-19. So they brought those into the human trials as well. They also wanted to make sure it was a diverse community. So Latinos, blacks, Native Americans, Asians, they wanted to make sure that they had those involved as well in the human trials. And they've done a fairly good job of having that done. And so that's one of the things the FDA does, is they get really down into the data, and they not only look at the data overall, but they look at it with specific groups in mind. How did the Latinos fare with this? How did African Americans fare with this? And do we need more information on this? If they do, they'll go back and get more information. But right now, it looks like they're getting all the information they need, which will become transparent. And so the rest of us have an understanding as well.
If I've had COVID and recovered, should I still get the vaccine?
If you've had COVID and recovered, the answer is yes, you still should get the vaccine. And here's why. Number one, if you think about it, 40% of people with COVID never have symptoms, and so we don't know firsthand if they had it or not. If you had COVID, if you were tested positive, then you know you had COVID. If you just think you had symptoms, may or may not have been COVID. But regardless, either way, if you have COVID, we don't know how long those antibodies will last. We don't know how many antibodies you actually have, because it's going to be dependent on your the severity of your symptoms, how long those symptoms lasted, and your immune system. And so what the vaccine does is it allows a baseline for everybody. Everybody gets the same dosing. Everybody gets the same amount of antibody protection built up based on their immune systems. And so we know we're getting that baseline set out there. That's important, because once we reach that herd immunity, having that baseline among everybody can go really far forward at getting this pandemic under control. If we eliminated people that had COVID, and again we're talking 20 million-ish people by the time the vaccines come out, then we're talking, we're kind of taking a bit of a gamble, because we don't know, number one, if they actually had it. How would we know? How would they prove it? Would they have to get antibody tested? Would we have to look at antibody levels to see if they still have sufficient antibodies? Have they worn off? All those different things. The vaccine gives them a good dose or develops a good dose of antibodies in their body. It helps them develop protections against COVID-19. It helps everybody get that protection essentially on the same baseline, which again can help the pandemic end. But thank you for your questions. These have been phenomenal. And again, going over headlines real briefly, the numbers, almost 15 million cases, almost 300,000 deaths here. The deaths and cases are both going up dramatically, so we need to be very careful, and that means over the holiday season, try not to travel too much. Lockdowns across the country, again, these are pre-existing criteria to establish those lockdowns. A lot of places have tripped that criteria, California, Colorado, Delaware, some places saying, hey, we need to keep people at home a little bit more, but these are going to be targeted, limited lockdowns, which is good. And then the vaccine, a lot of vaccine news coming. We'll have more news as the week goes on, because by the end of the week, we should know about the emergency use authorization for Pfizer, by the end of next week for Moderna, and possibly by next week or the week after, people can start getting shots in arms, and we can start getting, again, towards the end of this pandemic sooner rather than later. So thank you very much for these questions. These have all been fantastic, and I hope you, your loved ones, and your family have a wonderful, healthy, and happy